The next talk will be Modern Risk Stratification and Patient Selection, and this is Amir Labatchi from USC. Look forward.
All right. It's hard to follow art always, but I try. So patient selection for focal therapy. Thanks for everyone inviting me to give the talk today. There's a selfish pledge for our paper that's coming out as an invited review in PCAN. I'm going to review overall how we select patients, or how I select in my practice patients for candidacy for focal therapy. When I talk about or evaluate patients for focal therapy candidacy, I use 4 pillars. One is the lesion characterization, and there was a consensus saying we need good imaging to evaluate patients for focal therapy. MRI is so far the preferred imaging modality, but there's an emergent role for PSMA PET scans. Anatomical consideration, the proximity to vital structures or the location of the index lesion. Is it anterior, posterior? Disease characteristics, the Gleason score, the grade group. PSA as a molecular marker, is there a cutoff when we should not offer focal therapy? Or gene expression assays like GPS, Decipher. I like to use that in my practice as well. And then there are patient features, the overall health of the patient or the GU function, sexual or urinary function are very important. So the evaluation for patient candidacy is multi-factorial. So about lesion characterization, I think we had an extensive talks on that. Improved imaging and detection give us the ability to identify lesions, the ability to localize the lesion, and better risk stratify. Cancer. We are able to identify clinically significant cancer, localize the lesion, assess the volume of the tumor, and risk stratify the patient. So there's improved patient risk stratification and patient selection by using better imaging. And yes, there was a Delphi consensus now published 5 years ago, and the panel acknowledged back then that multiple imaging modalities are available, but the current standard of care is MRI, and it's most widely used and we have most experience with. But improved imaging allows better characterization. We had ultrasounds in the past. Yes, we were able to see the tumor here on the ultrasound. The error is a little bit off. Obviously, MRI, it's the same patient, shows us nicely this Pirates 5 lesion, and PSMA PET has further helped. That helps us if patients come with an outside biopsy and you're not sure if the laterality of the patient was correct, or if he needs a repeat biopsy. I like to use in my practice a PSMA PET scan to confirm the biopsy and the MRI findings from before. So it's great, going back again, to rule in a patient. But PSMA PET scans also help to rule out patients for focal therapy. This is a patient who was referred to me for focal therapy, has a nice lesion on the right side. I got a PSMA PET scan and it showed bilateral disease. The patient underwent the biopsy and we found on the contralateral side also cancer. So I use PSMA PET not just to rule in, but also rule out patient candidacy for focal therapy. The anatomical consideration. It's widely accepted to use focal therapy for patients with T2C disease or T2T disease or less. But more and more people adopt focal therapy of patients with EPE or extraprostatic T3A, extraprostatic extension. There should be really caution used if you use focal therapy for seminal vesicle invasion or bladder neck invasion, obviously. There was, in the UK, they looked into it, and the outcomes of patients with T3 disease, and they found that they were associated with higher failure rates. There was focal HIFU for stage T3 was significant. It was a significant predictor for failure, the hazard ratio of 3. Tumor volume. Back in the days when we didn't have MRI or good imaging modalities, tumor volume was a limitation for focal therapy based on random biopsies. We used to say single lesions with a maximum size of 12 millimeter on ultrasound, a maximum cancer percentage of less than 20%, a maximum cancer length of each core less than 7 millimeter, or maximum course with cancer less than 33%. But nowadays, we have adopted MRIs very widely, and the evaluation of cancer size is calculated more accurately. There are a couple Delphi consensus out. They say tumor lesions less than 1.5 millimeter are suitable for focal treatment. There are others say that a lesion size of less than 3 ml you can still offer them focal therapy as long as you offer hemigland ablation. Ultimately, you need to have a 5 to 10 millimeter margin. I use 10 millimeter in my practice as a margin. So with the better imaging, we're also able to optimize the treatment margin for focal therapy, and which is very crucial. Now, lesion location, I like to always talk about my northern and southern hemisphere. Patients with tumors in the posterior aspect of the prostate, I like to use transrectal energy modalities because the posterior peripheral zone is easier accessible through the rectum. It's the shortest energy source to tumor distance. Anterior tumors, transperineal, I like to use a transperineal approach, avoid the rectal and urethral injury. By bypassing them, it's the shortest energy source to tumor distance. Again, it doesn't mean you can't use transrectal approaches for anterior or vice versa, and transperineal techniques for posterior lesions. But it's easier to think, and I think Dr. Sanchez-Salas used the term a la carte approach. I like for my northern hemisphere tumors, I prefer cryo and IRE for the posterior HIFU. But again, that doesn't mean you can't use one for the other, especially once we gain more experience with each energy modality. But the lesion location helps you choose the right energy modality. What about disease characteristics? This is one of my favorite slides, adopted from my partner, Andre Breu. So low-risk cancers, we like to offer active surveillance. High-risk cancers undergo radical treatments, radiation or radical prostatectomy. But there's a sweet spot, the intermediate risk, GG2 and GG3, which are the best candidates for focal therapy. But what about the patient with a low-risk disease, has a high PSA or PSA density, or a low volume grade group 2 disease, or patient just doesn't want to just sit with his grade group 1 disease and wants to undergo treatment? On the other end of the spectrum, what about the high-risk patient who has one core of grade group 4 disease or a small volume of grade group 4, but he doesn't want to undergo radical treatments? There are gray zones, and we should probably tailor the treatment to the patient. But if you talk about the ideal patient, it should be unifocal, or some say unilateral, clinically significant disease. It should be clinically significant disease. I don't like to treat Gleason 6. Any pattern 4 should be on the pathology specimen, and disease should be isolated from vital structures. It should be MRI visible, but in future it might be switch out with other better imaging modality. Absence of high-risk features like cribriform pattern. What about the prostate size? I think size becomes less and less important as we tailor the treatment to the patient. I think as long as you can reach the energy, the tumor with your energy, prostate size is not really an exclusion factor. Using PSA, so PSA is a known biomarker. We use it also in the follow-up to see how much the PSA drops. There was a consensus initially. They said focal therapy should be used for patients with a PSA level less than 10. More recent consensus statements say you can use it in patients with 10 to 20. But the decision about performing focal therapy should not be based solely on a PSA level, especially because it's a very volatile marker which can be influenced by a lot of factors. And the expert opinion right now says that patients with higher PSA should undergo further evaluation to rule out the presence of extraprostatic disease manifestation. What about other gene expression assays? This is an abstract from Dr. Polasic's group. He was kind enough to share with me. I like to use GPS and Decipher scores in evaluating patients' candidacy. And he basically looked in a retrospective analysis what the cutoff was for worst outcomes based on post-ablation biopsies. And they use a GPS of greater than 40 as a prognostic indicator of treatment failure and biopsy recurrence. What about patient features? And I'm almost done. So basically, there are two columns I think about. The overall health of the patient. We use the same guidelines as other major guidelines for robotic prostatectomy. The patient should have at least 8 to 10 year life expectancy to offer them. But there's no upper or lower boundary age-wise when you offer patients focal therapy. About the genitourinary health, patients, these are important. That's why the patients begin choosing focal therapy. But initially they said if they have too many lots or urinary symptoms, they should not undergo focal therapy, but mild to moderate LUTs are not contraindications for focal therapy. And a lack of erectile dysfunction, a lack of erectile function shouldn't disqualify a patient getting focal therapy. So, it's not a disqualification if they don't have any sexual function. What are the challenges we still face? Multifocal disease burden. Should they be excluded from focal therapy? I think right now, in my practice at least, they're excluded, but maybe in future we can think about it, offering patients multifocal focal therapy as well. Imaging invisible disease, I think we had many talks, including from Dr. Klotz, invisible disease, is it actually significant? Should we treat these patients or not? And what are the role of biomarkers or gene expression assays? There's a potential to improve patient selection for focal therapy. Thank you.